Good morning, good afternoon, good evening, everyone. Welcome to this Inclusion Network meeting from the Atlas Alliance. My name is Gagan Shabra. I'm the project manager for inclusion at the Atlas Alliance. And we are extremely elated to have you all here with us from all corners of the globe for this important meeting. It's called as Mental Health Matters, Combating Discrimination, Overcoming Stigma, and Promoting Inclusion. We have an eclectic panelist with us from across the globe. And before we dive into the conversation with regards to mental health, why it matters, and how do we overcome discrimination, and how do we promote inclusion, a little bit of housekeeping from my end. Number one, this meeting is getting recorded. Number two, this meeting is facilitated with sign language interpretation services. This meeting also has closed captioning, and if you want to have the closed captioning on, you can go down to the bottom right corner of your screen and click the CC button and it'll be on, so it's facilitated. And the plan for the event is something to this effect, that we will have brief presentations from all the 5 panelists from across the globe. And after that, if we get the time and opportunity, we will have a Q&A and discussion section. But the most important thing is for this meeting is to share knowledge, best practices, and lived perspectives on the theme of mental health, which is often neglected in the domain of development aid. So before I hand over to the panelists, a couple of other important points. For any questions in regards to technical facilitation, contact Johanna, my colleague. She is there. Drop a message on the chat box. She'll be able to respond to it. If you have any questions in general, you can write it down in the chat box and we'll try our best to ensure that it gets answered. And if not, then we can get back to you at a later date. So now I'll just give a brief presentation of this particular theme, mental health matters. Some weeks ago, there was a report which caught my attention. The report was from World Health Organization, and the report was titled World Mental Health Report. And I just checked the subtitle and I found it out that it's very, very crucial that this issue now of mental health has become a burning issue after the COVID pandemic, because the World Health Organization estimates that there are more than 1 billion people around the globe which suffers from mental health conditions. This could be depression, anxiety, psychosis. And the shocking thing was something to this effect, that almost $2.5 trillion are lost to the world economy because people have mental health conditions. This reduces their employment, it causes productivity losses to a tune of almost $1.7 trillion, and $0.8 trillion are lost because of mental health treatment costs globally. And another shocking thing which kind of caught my attention when I was listening to that report is something to this effect, that this mental health issue affects individuals in both the global north and the global south, and only 0.3% of the budgets with regards to health are being spent on mental health issues when you think about global assistance, development assistance. And as compared to that, 50% of global development assistance is being spent on sexual and transmitted diseases. So I'm just perplexed that why this is happening, that when so many people are affected by mental health conditions, when mental health conditions lead to situations wherein people commit suicide, people go into deep depression and they are not able to be productive members of the society. They're not able to participate in the community. They're not able to finish their schooling and education. Why is it that we are not taking enough action when it comes to issues linked to mental health? And why are we not centering this theme? So that was the reason why Atlas Alliance, we thought that we have to bring the conversation on mental health and bring it closer to the development sector and remind ourselves that yes, when it comes to international development, we have to focus on the theme of mental health inclusion, and individuals with mental health conditions have to be ensure that they are part of the conversation and they lead the charge. So now we have an eclectic group of panelists with us. And before I hand over to our first panelist, a quick note of visual description about myself. I am having long, dark, curly hair. I'm wearing a black t-shirt. I have a turquoise shirt, which is open. And I am right now sitting in an office space in Oslo. And on that note, I would like to now invite our first panelist from Uganda, Mental Health Uganda, Mr. Derek Kisa. Derek is the executive director, and he's going to enlighten us up and share some perspectives linked to mental health conditions from Uganda. Derek, the floor is yours.
Thank you very much, Gagan. Thank you very much, Atlas Alliance, for organizing this webinar. Like you have introduced me, I am Derek Kiza, and I am wearing a kind of black shirt. I am chocolate brown in the color of the skin, and I am seated back here in the office in Kampala, at the Mental Health Uganda Secretariat here in Kampala. Just to give a little bit of perspective, we do not have actual statistics on the number of people with mental health issues or disabilities in this country, but at least from the Uganda Bureau of Statistics, we can see that the prevalence of mental health conditions in Uganda increases with age. So they report that about 5.6% in children at least 2 to 4 years, and 9.4 among adults. That's according to the Uganda Bureau of Statistics report 2018. But also to note is that Uganda has the youngest population in the whole world after Niger, with about 48%, just under 15 years of age. And according to WHO, we know that about 75% of mental health problems start by the age of 24, and then about 50% age of 14. As a country, we have a health policy framework that encompasses decentralization and integration of mental health services into the primary health care. However, the mental health policy has remained in draft form since 2011. And it's also important to note that about 0.9%, so just about 1% literally, of the national health budget goes into mental health care. And of this, 85% goes into the national referral hospital for mental health here in Uganda. But also, what I could say is that persons with psychosocial disabilities still experience worse forms of stigma, discrimination, abuse of rights compared to the general population. And you could see that from the Uganda Bureau of Statistics report of 2018, that 1 in 4 with psychosocial and intellectual disabilities actually experience sexual violence. But also historically, having a psychosocial disability has always been a ground for systemic and legalized injustices, including forced institutionalization and treatment, but also incarceration. And just to go into this a bit, the Mental Health Act of 2019 still grants healthcare professionals to use electroconvulsive therapy, seclusion and restraint. And yet we are aware that the Prevention and Prohibition of Torture Act of 2012 actually identifies solitary confinement as a form of torture. So WHO also insists that there is no therapeutic evidence to back up these forms of coercive treatment as effective in the treatment of people with mental health problems. But also, even when you look at the involuntary patients who move by themselves to hospital, the practitioner might have take a decision, literally, to retain them, even when they brought themselves to the hospital. So then you have challenges with informed consent, but also we might know that psychiatric hospitals are by and large not places of recovery for many. The time spent admitted is usually against their will, and they are often subjected to these kinds of coercive practices. But I would also like to say that institutionalization and incarceration is also often practiced in homes, communities, by relatives or community members. So in summary, in terms of perspective, you can see that arguably the most discriminated and stigmatized are people with mental disabilities, especially when you're making comparison in terms of all disabilities. This is where you found unfounded fears, negative stereotype, lack of knowledge, but also it's an area that is under-researched, which literally affects policy development, because you see annually here in the Ministry of Health budget having research on Marburg, on Ebola, on nodding syndrome, but then you don't see research coming out, especially on the social and human rights aspect of mental health. And statistics, it also explains why we don't have the statistics. So just like other low and middle income countries, stigma determines how we draft our laws and policies, how we implement them, and how the community embraces and rejects persons with disabilities. And you could see this in the discriminatory laws and policies, discriminatory judicial service system that we have here, the exclusion from community through institutionalization, which I talked about, and limited finance given to mental health specifically, and then denial of support services and access to the preventive mental health services. So you can hardly find community mental health services. It's more of the institutional kind of intervention, and also poverty and financial constraints at family level. But as Mental Health Uganda, we have been strong champions of lived experience leadership, which has helped to normalize mental health conversations. We have also been able to pilot social contact within Kampala. It has also been approved by the WHO. Social contact is a situation where a person with a lived experience literally starts up a conversation with a person without. And the intention is to try and address the stereotypes, wrong perceptions that people have about people with mental health problems. The results are very massive, they are very encouraging. We also have a national toll-free line in partnerships with our colleagues from Mental Health Youth Norway. And literally, results are very encouraging. By the end of Q2 in this year, we had about 54% of callers who reported that they had not accessed any form of support before we actually had the teletherapy. We also do a lot of advocacy around human rights, community-based services, and we also rehabilitate homeless people with mental health issues on the streets. And this is something that we have been doing largely in the center of the country here in Kampala. We also provide legal aid to support litigation, documentation, building capacity of membership to be able to report some of these cases involving human rights abuses. So in summary, I want to go into why it's important to change this kind of narrative and how. I certainly think that it's important to normalize mental health conversation like it is for other illnesses, malaria, tuberculosis, and recently COVID-19. Otherwise, if we don't do this, then we run a risk of losing more people literally to mental health problems than COVID or any other. But also secondly, it's important that we pilot and document evidence-based approaches, including the MHGAP, the social contact I talked about, because some of the initial results have been very encouraging, but we've not seen government moving towards supporting the application of these very successful approaches. But also lastly, it's always still important to promote lived experience leadership because it increases the credibility of the messages and also enforces the spirit of nothing for us without us. Thank you very much.
Thank you so much, Derek, for such a thought-provoking presentation. And the fact that you underscored is very, very crucial that that institutionalization and incarceration is often a major problem for individuals who have mental health conditions or psychosocial disabilities. They are often forced institutionalized. And also much gratitude for underscoring that social contact approach wherein lived perspective leadership or individuals who have had mental health conditions are engaging with those who don't have it so that you can bust myths, create knowledge, create information, and ensure that the stigma which is associated with mental health conditions dissipates as time progresses. Thank you, Derek, for that. Now we'll move to Ethiopia from Uganda, sticking still to the beautiful continent of Africa. I would like to invite Fikerte Taragin. Fikerte is associated with the TOFI Consortium, the Together for Inclusion Consortium, which Atlas Alliance is funding. It's a DPO-led consortium and is an organizational psychologist and psychologist. So Fikerte, the floor is yours.
Thank you, thank you, Atlas, for having me in this discussion.
Fikerte, pardon me, we're not able to hear you. Could you please come a little closer to the microphone?
Okay, now?
Yes, now it's a lot better. Can you please say something?
Okay, thank you for having me on this panel discussion. You know, as you say, I'm from Ethiopia. Most of you might know that Ethiopia is in Africa, in East Africa. It's the second largest populous country in Africa. And when we look at the mental health and psychosocial disability service in Ethiopia, there is a very huge shortage of psychiatrists professionals in the country, as well as other like psychologists, social workers, and also psychiatric nurses. And also there is a lack of care providers at the hospital. Also, there is a lack of resource in the mental health areas.
Fikerte, pardon me, excuse me, can you please come a little closer to the microphone? Your voice is not a little clear. If you could try once again, saying the last part. Thank you.
Is that okay now?
It's a lot better. Thank you.
Okay. So when we look at the situation of mental health and psychosocial disability in Ethiopia, there is a huge shortage of psychiatrist professionals. As you know, Ethiopia has more than 100 million people living in Ethiopia. So we only have like 18 psychiatrists, and also there's a shortage of psychiatry nurses as well as psychologists and social workers. in mental health service provision areas. And with regard to childhood and adolescent mental health services, there's only 2 hospitals which provide psychosocial supports for child psychiatrists. And also there's only 1 psychiatrist in the Ethiopia. And when we look at the prevalence of mental health disorders in Ethiopia, it's found to be 11% of the total burden of disease. This is not the exact prevalence rate because nowadays, as you know, Ethiopia is in a very fragile situation. There is a conflict in different parts of Ethiopia. And also there is a drought, displacement, and economic inflation in the country, which affected the prevalence of mental health situations in Ethiopia a bit higher than what has still now. When we look at the specific prevalence of mental health disorders, like common mental health disorders, like common mental health problems, found to be like 21.6% of the general population. And when we look at the suicidal rate of the Ethiopian mental health problem, mental illness, it's found to be like 7.9% in 2005, but after 10 years, it reached to 8.4 per 100,000 population. This suicidal rate is very low because there is a stigma attached to the suicide. So most of the suicide were not reported properly. So we couldn't say that it is the exact amount of the suicidal rate. When we look at the severe mental health problems like schizophrenia, bipolar and major depression disorder and alcohol disorder, they are found to be like 0.5% up to 1.9% for alcohol use disorder. And when we look at this mental health situation with neurological disorder like epilepsy, it's 1% prevalence. When we look at the childhood and adolescent, when we look at children with psychosocial disability in Ethiopia, that means like mental disorders like ADHD, oppositional defiance, anxiety disorder, mood and autism spectrum disorder is found to be like 50% of the total mental health disorders in Ethiopia. When we look at the stigma and discrimination in Ethiopia, there are misconceptions about the causation and the causation of mental health problems, because most of the time we believe that in Ethiopia, they believe that mental health situations are happen because of supernatural power, evil spirit, and it affects how they take the treatments. Mostly they go to a traditional healer or a church or a mosque for religious helps. To mention some of the stigmas and discrimination in Ethiopia, one of the attributes that child develops a behavioral problem when the family is punished by supernatural forces of parental or ancestral sin. And the other one is like caregiver of people with mental illness associated themselves from social life due to fear of public stigma and discrimination because it's associated with supernatural cause. So the caregivers also blamed for having a kid with mental illnesses. There is also self-stigma, which is related to history of traditional treatment due to higher perceived supernatural explanation. So most of the mentally ill people are isolate themselves for even service, for accepting services. When we look at the marriage status of especially severely severe mental illness people. Most of the time, they are not engaged in marital relationship due to the perceived attachment with like they are called as a dangerous people, and the problem are not solved by a scientific or a medicine. So mostly they are neglected and they are not associated with the society to get engaged in familial activities. And when we look at the children with the special needs, they are easily mislabeled and neglected in the school, in the community setting. Because if we see like ADHD kids, most of the time they are taught to be like a nasty kids, so they are not included in the systems. Even in the education systems, they are somehow not systematically neglected, but they are neglected indirectly by the teachers in the school compounds. When we look at the intervention pertaining to mental health and psychosocial disability, there is the sustainable method for reducing mental health burden to prevent mental illness and promotion of mental health and protection of people and psychosocial disability through integrated and responsive mental health and psychosocial care services at the school as well as in the community setting. To mention some of the possible interventions, there should be like organizing different mental health awareness campaigns through mass or social media on promotion and prevention in mental health and the rights of people with mental health and psychosocial disability in order to reverse the myths and wrongly held beliefs and negative attitudes. And also it's good to enhance the interaction and connection between people through sharing of lived experience, recovery stories, and challenges so that the public can overcome fear, build self-esteem, and develop empathy for mentally ill peoples. And also it's good to create an advocacy network with different ministry, government bodies to promote the inclusivity of students with psychosocial disability. Mostly we in Ethiopia, there's no a shortage of legislation or a law. We have the laws, but there is a gap in implementation. So there should be a body to coordinate this kind of things to check and balance the laws and the legislations. Because we have a national mental health strategy for the second time. We have also legislation for like criminology of mentally ill people, but there is a gap in the implementation of these legislations. It's also better to increase the number of specialized professionals for children in use in the school as well as at the hospitals, because at the school we found that even in Addis, it is good because we have especially professionals at the primary education level, but in the secondary, there is only counselors. But out of Addis, it is there is no any especially professionals in the primary education level. So mostly kids with special needs like ADHD, autism, and conduct disorder kids, they couldn't get the chance to be understood by the school community. So it's better to prepare the service for those needy kids. And also it's good to allocate special need professional, educational psychologists, to social workers and counselors at different level of the school systems, because we in the primary level, we have special need professionals. We don't have educational psychologists or counselors. And in the secondary level of education, we only have counselors. So kids who are struggling with different difficulties like autism and ADHD couldn't have a chance to get a better service in the secondary education. So it's good to have those professionals, even the secondary as well as the tertiary education level. And also we believe that it's recommended to use multi-sectoral mechanisms to amend the law of the country and enforce adherence to the CRPD, because it's very important to use the CRPD because it values the rights of the kids of person with disability, and it helps to the society to understand who are they and what is they value, what value they have in this kind of things. So to mitigate this mental health and psychosocial disability, TOFI Ethiopia is working with the school, communities and TPO, as well as NGOs. So as one of the consortium member of TOFI Ethiopia, Natalie is working in awareness creation in school and through organizing training, psychoeducation, discussion sessions with the students and teachers, parent-teacher associations. And also, we also assign psychologists at school and hospital to provide psychosocial supports like individual counseling, group counseling, as well as family counseling. And also there is also some support group facilitation also. To mention one of our best practices, we prepare different manuals with regard to disability and psychosocial disability as well as mental health. But one of our manual is mental health and psychosocial support for teachers, students, and PTA members in collaboration with ADRA Ethiopia. So the manual was prepared by the consortiums and was a very good, we get a very good impression from teachers as well as the school community. And thank you so much for having me.
Thank you so much, Fikrate, for such a wide-ranging conversation. Your presentation was very, very powerful. You accentuated the issue of spiritual, supernatural belief systems or evil spirits, which are often associated with individuals who have mental health conditions or psychosocial disabilities. And as a result of that, these individuals or children could be chained or locked up and could be hidden away. And that is extremely harmful practice. And also, many thanks for mentioning the role of media awareness campaign and the important role which TOFI Consortium is doing to change the lives of children with disabilities in Ethiopia. For those participants who don't know about the Together for Inclusion, TOFI is a consortium. You can check out the Atlas website and you'll find important research material, reports with regards to the projects which have been implemented across different African countries. And this is a very unique consortium wherein DPOs, or disabled people's organizations, are in the lead when it comes to implementing projects, which Fikrate was mentioning as well in the end. So thanks. Now moving on from the beautiful continent of Africa, wherein we had two presentations from Uganda and Ethiopia, we'll move towards India. We'll listen to one of a prolific speaker, Bhargavi Dawar. Bhargavi is the executive director at Transforming Community International and has been a pioneer in the field of mental health rights advocacy for decades. Bhargavi, the floor is yours.
Thank you so much, Gagan. Can you hear? Am I audible?
Yes.
Yes, Bhargavi.
Yeah, thank you so much. I am wearing a gray shirt and glasses, short hair. I should have gray hair. My background, I'm against my background of my working space at my home. And my location is Pune, India. This is on the west side of India. And my computer right now warns me that my internet connection is unstable. We have like very rough weather here, and I hope so I shall be able to pass my message through. I'm very happy to join this program today, and very happy to also meet my fellow panelists and of course Gagan and people from Atlas Alliance. I used to talk a lot about mental health, but over the last years, and especially after the advent of the Convention on Rights of Persons with Disabilities, this convention had a long-lasting, life-transforming experience on my life and my advocacy. So we have cut down quite a lot on talking about mental health. The organization which I started many years ago, we used to say that we are a community mental health program. These days, we say that we are a community inclusion program. Slowly, the language, the narrative shifted from talking about good mental health services, nourishing mental health services, to full and effective inclusion and participation in all aspects of life. That has been a paradigm shift for us in very practical terms. The CRPD gave us this idea that we need to focus on paradigm shift. We need to move from the medical model to the social model of human rights and disability. And in this one claim for the CRPD, there is a world of difference. There is a world of difference in terms of policy, in terms of practices, in terms of how even human beings and communities and families relate with each other. We continue to unpack the full implications of this statement over the years, and it took us about 10 years to arrive at this finding, this learning from our community project in India, that no amount of good mental health services will result in inclusion. That inclusion is a separate programmatic strategy for which field workers, managers, organizations need to be trained. They need to be inculcated into the value of inclusion. We need to be reading more on inclusion. We need to be experimenting, creating new pilots on inclusion, and so on and so forth. I would like to detail this a little bit because there's a lot of talk about the alarming rise of mental disorders. Yes, there is. And Corona did not make it easy for any of us, particularly young people. It's the worst thing that young people ever saw. So there is that. There is a rising, alarming rise of mental health experiences. So we have gone. There are so many outliers from what is considered normal mental health experience. Now, the question to ask is, was there ever a normal mental health experience? While I was talking briefly with Gagan in preparation for this meeting, he was challenging the idea on normality. And Corona has pushed us to think about that question even more. The DSM moved from like 50 diagnoses to 250, 300 diagnoses in its latest version. Does that show respect for human diversity? We all experience emotions in different ways. Men and women and all those in between, that spectrum, they experience their own selves in ways. Who are poor, their experiences do not compare with people who are super, super rich. That's part of the human diversity. So, whatever the number of diagnoses we are able to generate, the attempt to fix human beings in the spectrum of normalcy, it is reductionistic. It will not end this kind of categorizing, until we reach the point that every person can get a diagnosis because of the very individualized way of experiencing life and what it brings them as barriers and facilitators. And I think that's the key message of the Convention on Rights of Persons with Disabilities. The disability experience is not just how many medical conditions we have, how many medical conditions is in us. It's not about fixing the individual and those medical conditions. The disability experience is all the varied health and other experiences we have, along with legal, social, attitudinal, economic, cultural barriers. That whole package constitutes the disability experience. So when we started looking at paradigm shifts, starting different kinds of questions. When we say, how do you treat a mentally ill person? Which, by the way, we never ask this question in this way because it is quite stigmatizing to call someone mentally ill or bipolar. So many of us used to call ourselves that several eons ago. We have then thereafter tried to retrieve our dignity by finding other names for ourselves. And persons with psychosocial disabilities works for us in the Global South. So when you ask this question, how do you treat? Then there is a range of things that the systems do, like how many beds, are medicines available in the primary healthcare sector? Do we have enough number of psychiatrists? Do we have psychologists? Is it a trained multidisciplinary team? So on and so forth. This is the medical model. Look at the paradigm shift and look at the inclusion model. You will say, do people have support networks? Are the communities inclusive? Are people able to freely access jobs, or is their treatment a barrier for them to get jobs? Are there legal barriers for their inclusion? So every door of the CRPD opens up a new opportunity for inclusion. And when we realize that, we move slowly from the mental health treatment model to the inclusion model in the communities. And when we engaged with the cross-disability movement, who are our the closest ally, we started saying that our experiences are very close to people with, who are deafblind, who are deaf, who are persons with mental, intellectual disabilities, with people with multiple disabilities, because the level of social, legal, attitudinal exclusion is common across all these groups. Then we started looking at, how we can engage communities on the topic of inclusion. And that's why we got the name Transforming Communities for Inclusion. We are not saying, users and survivors of psychiatry or consumers of mental health services. The organization that I lead now internationally, it's called Transforming Communities for Inclusion. Because a person on their own cannot initiate and sustain and maintain, conserve actions on inclusion. Societies around them, the milieu around them, the spaces around them, all the actors around them need to adopt a culture of inclusion. And then communities itself change. So that's the kind of framework that we have worked with. And sometimes we use many, many metaphors to build practice at the community level. How do you actually practice inclusion in, say, a low-income community in Pune city? TCI partners with the Bapu Trust, which has the largest population-based peer support program for the Global South, and people say possibly for the world. We work with about 800,000 people offering peer support and group support and other inclusion services. To close with one example of an inclusion action that people take in my program. We call it the circle of care. So when there is a person who is seen as having a high support need, is withdrawn, is staying inside the house, not talking, not eating, no social engagement, then the program people set up a network of support persons in the neighborhood. It's a neighborhood strategy. So they mobilize for awareness. They do extensive awareness around disability inclusion. And they do a lot of befriending activities. It might just be leaving some food for the person, attending to basic needs, alerting a neighbor to support in terms of care, a variety of actions. When there is violence against this, the community members are supported to mobilize to stop the violence, negotiate with people perpetrating the violence, and so on. And in this instance, we also look at institutionalization as a form of torture and violence, and we intervene with community justice actions like the one that I just described. People do mobilize around, rally around prevention of taking this person into the nearby mental asylum. So I think the kind of actions, we say that this person who is isolated in their homes is facing a kind of institutionalization. Their lives in the community, open communities, is interrupted because of various barriers. And our job as support people is to remove those barriers one by one. The program is called Seher, and we are very proud that it is there is zero compliance, zero coercion. There is CRPD compliance. We have never institutionalized anyone. We have prevented many people from being institutionalized. We've offered a variety of support actions for them, which go well beyond mental health. And I think so that's where I'd like to stop, because I'm sure there will be like many questions around this rather provocative. It's no longer provocative because this is what the CRPD is talking about, that we need to arrive at a point of inclusion for all persons with disabilities. And over 15 years, I think many of us have had excellent chance at piloting and testing out new practices. Thank you so much.
Thank you, Bhargavi, for that thought-provoking presentation. And I think you're hitting the nail on its head when you are talking about shifting the paradigm. It circles back to Derek's point as well, when he said that recovery does not take place in the hospital, or when we think of individuals with mental health conditions who are psychosocial disability, that they have to be treated or fixed or cured. That's the old paradigm. The new paradigm is the paradigm for inclusion, that how we foster resilience, how we ensure, build systems, build support mechanisms, change the surroundings, make places and spaces for individuals to thrive, so that communities take responsibility as well, and we become much more flourishing. And the circle of care is something which is a very powerful strategy or tool which you are using, and I would invite the participants of this Zoom meeting to check that out as well. It's very powerful. It's similar mechanisms like the social contact in Uganda. So now we would move from Bhargavi in India to another participant from India. Her name is Shrutila Singh. Shrutila is a phenomenal disability rights activist. She works for Sense International. She's deafblind. Shrutila, the floor is yours. Please share your perspectives. Thank you.
Hi everyone, thankful to Gagan for this opportunity. And my name is Shrutila Singh, and I am currently sitting in a hotel room with my amazing interpreter. And I have tied my hair inside bun and I am wearing a dark top with white spots. So I have progressive deafblindness. Here the word progressive means that I am losing my vision and hearing day by day. And currently, I can see very little, less than 5%, and can hear only noises. But earlier, I was able to hear and see much better. That is why I am able to speak now. And I have completed my English majors and also diploma in physiotherapy from Association for the Blind, and have worked for 3 years as a pediatric physiotherapist. And now, since last 2.5 years, now working with SENS India, the only national ever organization working for people with deaf blindness, to take forward the issue of rights-based advocacy for people with deaf blindness nationwide. And because deaf blindness is a unique disability in which two of the main senses are affected, vision and hearing helps. Whatever we learn, 95% of what we learn is through vision and hearing. And in deaf blindness, our vision and hearing are affected in varying degree. So we face a lot of challenges in communication, socializing, and different things. And in my case, I have progressive deaf blindness. So I have to adapt life in life and adapt to the changing things. Like was able to read and hear, but now I'm not able to. I'm slowly losing words. So I have to adapt with it. And adding to all this, my gender, being a girl with deaf blindness, adds to the challenges, because I live in a country, developing country, where we hear about various crimes against women. And for safety purpose, I had to be more isolated. That means I had to stay home with my parents mostly. And during school time, my classmates and teachers used to discriminate me, and they used to make me sit separate from them. No one liked to sit with me. At times they also treated like they would get some infection if they even touched me. That's why they tried to keep distance. And all this behavior added to the mental stress that I was already feeling because of hearing impairment, and I was not able to socialize because I was not able to hear properly what they were speaking. And they used to speak in such loud way and very aggressive manner that also added to my mental health stress. And through all this, it was very difficult to cope at that time. And at the age where students were making friends and enjoying with friends, going out, I was very much depressed, isolated, and had no one to share with. And also, I was desperate for friendship also. And in school, I didn't learn either academics or socializing skills. Today, I have come a long way, and I have learned socializing skills, and we can socialize with others. But the feelings and challenges still remains the same, because I have severe communication issues, and I cannot fully participate. It is not like my family and friends do not want to talk with me, but my communication with them is very much limited. I mean, I do go to attend family functions and do go out with friends. I love to go out with them, but in the end, I end up feeling lonely because they can chat and talk about various topics. And what do? I just sit there trying to fit in, but that is very difficult. Whereas an advocate for deafblind, I work with a network of people with deafblindness nationwide, and many of them, especially those with progressive deafblindness, have more or less same issues that I am facing. Because it is not just us who have to adapt, but also our family and close one. Because earlier our problem was not that much, but with time, especially when our parents are growing old, they have to adjust. And how do we communicate at home also? I do go for wedding, to attend wedding and everything. I try to enjoy, but in the end, I feel like I am not able to do anything, and in the end, I lost interest. And whatever I had faced in school, their behavior made me feel very inferior compared to others. And also, I felt very depressed. There was no feeling of self-worth. It was very bad experience. And most of those in my network also share things like this, because they say that the negligence of people with disabilities and also bullying of them are still ignored. And I do keep on trying to raise my voice now about various things, but mental health is something that we are still not talking about. People tell me that I am very inspirational because I have achieved a lot of things in my life despite my disability, and also I stay positive all the time. But what they don't know is that it takes a lot of effort to stay positive, because it is an everlasting challenge to fit in even with friends and family. And every now and then I have to pick myself up to stay positive. And I have to, sometimes I even feel distressed, because earlier I was able to hear and was able to listen to my music, but now I find that I have very limited choices and I cannot even read the books, my favorite books, because my eyes get tired easily, and I cannot hear those music that I used to love. These all feelings push me in depression at times, but now I have to try to figure out new ways and focus on positive ways. These are many challenges, and even now, every morning I have very negative thoughts, scary thoughts, and what will happen in future like that. But I try to focus on positive things, because mental health is very important. And I remember that years back, I did got fed up because of all the bullying and all the negativity that I had in my life. And once I tried to sell a poisonous pill, but in the end changed my mind just when I was about to sell. Because thankfully, because I thought about my parents, what will happen to them if I do that. Even today, I get very depressing thoughts when I get too much headache due to vision issue and vision gets blurred. And then I have to find ways. What can we do then? This is challenge that many of us face, whether it is school or community or anything. CRPD mentions about meaningful participation. But what exactly is meaningful participation?
Shrutilata, are you there? I think we lost Shrutilata there because of Wi-Fi connectivity issue, but I would like to underscore or highlight the point which she mentioned, which is so powerful, that it takes a lot of effort to stay positive in the midst of all the isolation which comes out of being deafblind. The fact that she was unable to communicate with her family and friends, and she progressively felt herself to be alone, and to a point wherein she thought of taking her life, is something which is worth underscoring, that often mental health conditions could intersect with individuals who have other disabilities as well. So it's a very pressing issue. Now we can move to the final speaker panelist. And if Shrutilata joins us later, perhaps we could have her on again. Our final speaker is from Norway. Her name is Kristin Elise Schade. Kristin is an activist in the domain of mental health rights. And Kristin, the floor is yours.
Oh, thank you so much. My name is Kristin. I'm 22 years old, and I am currently in my apartment in Oslo in Norway. I'm wearing a very pink, like greenish corset top. I have a shaved head, and I'm wearing glasses. First of all, thank you so much for having me, and thank you to all the other panelists for their presentations. It's really interesting to see how mental health really can affect each and every one of us, no matter who we are. Issues linked to mental health conditions such as depression and anxiety can strike us all, no matter our age, gender, race, sexual orientation, economic class, or national background. In other words, mental health does not discriminate. For an example, our Public Health Institute claims in their own research that about half of the grown Norwegian population will have to deal with mental health problems at least once in their life. I and myself are battling psychosis, and I've been battling psychosis for almost my entire life. That means, in a very short summary, that I experience things that other people don't. I hear voices, I can see and I can smell things that other people don't see and smell. And if I don't take my medication, my mind tricks me into this really scary world where I have no control and I feel like I'm in danger. And one of the hardest things about having a diagnosis like psychosis, in my opinion, is all the stigma around it. I come from a small town called Seljord, where we are less than 3,000 people, so everyone knows about everyone. You are expected to fit into some kind of mold in a sense, and there is quite a mentality that you should not be different in any way. You should be like everyone else. If you do stand out, either because of how you look, how you act, what you're battling, or basically just because of who you are, you're more likely to be bullied and having a really hard time. I really struggled. I was battling this harsh diagnosis and I felt completely alone. I still felt that I had to meet the expectations of me being a normal child, a normal sister, a normal friend, and a normal student. That there was no space for me to be sick in a way. I really felt like a burden because of my diagnosis. My days were unstable. Some days I ran away in fear from my hallucinations. Other days I just slept, and other days you couldn't even talk to me because my voices were too loud. Even though my parents were indeed amazing, they always supported me. But I never felt that I was enough in some kind of way. I felt bad because my school had to make all of these adjustments to make me fit in. And I felt bad because I had to turn down my friends because my days were too unstable. And I felt horrible not being normal, like everyone else. I chose to be open about my illness after a while, and I started to write a blog. I was hospitalized, and I documented almost my entire journey. It was really difficult and hard for me to do that, but I still knew it had to be done. If me being open about my illness could help at least on one other person, it would all be worth it. And while I had this blog and was open about my mental illness, messages were ticking in, as well as comments around school. Most of the messages were from other people opening about their own struggles. And they were people that I would never have thought would have struggled. They were people I looked up to and who I thought, naive as I was as a teen, that were too perfect to be struggling with the mental health. That really affected me, and I realized how many people it really affects everywhere at all times. But on the other hand, people were also getting scared. I would get really awful and uncomfortable questions and comments, especially when I attended parties. Questions like, oh, so you're one of those who murder people? Or that they had to be careful because I was dangerous. And let me just put one thing out there, just really quick. I have never ever been a danger to anyone else than myself. And the one person to really be negatively affected by my illness is myself. I felt really insecure about being open. And I do understand why, because people were afraid, people were insecure, and they didn't know how people would react if they was admitted to struggling. I have friends who couldn't even say that they were going to the therapist because it would be looked at as some kind of a weakness. They faked all types of different excuses for other places they had to be, when in reality, they were battling this invisible fight that no one else could see. They were brave enough to seek help, and more importantly, the help was there. People were afraid, and they still are. They're afraid they will lose their friends, their family, and their social life. And why? It's the simplest reason ever. It's because they're human. School was really difficult for me, and I've always been really good at school, but my struggles with psychosis suddenly made everything harder for me. Either it was about reading, concentrating, or even showing up. Everything was a struggle, and my mind was at a war with itself. I still haven't finished upper secondary school, and that's okay. I've done a lot of other things. I have volunteered a lot, tried to work some, and of course, I've gotten a lot of help. Some of the key factors to why I am now in a place where I can sit and hear and talk to you about it is because my support system was there. My family, my friends, and the health system, they all were there, and they still are. I am, however, dependent on a medication shot every 3 weeks, but instead of me being hard on myself for my diagnosis, I'm trying to use it to create a better world. I am currently volunteering at Mental Helse Ungdom Norge, which is a mental health organization. I have also traveled around at different schools to talk to students about mental health, and I'm now using my own struggles to help others. I am still afraid, however, to tell new people that I have a diagnosis of psychosis, because my previous experiences have told me that people will back off. They will be scared, and they would just like back off, and that really scares me. But I have come a long way, and I am optimistic about the future, both for myself and for everyone else, even though there is still a long way to go. There are, however, a few things that we can do, and I really want you to do. Accept that there is a mental health problem, accept that it can happen to anyone, and it does not make you a worse or weaker person at all. I've gotten a lot of help by having the correct medication, but I think the other main key factor to me getting better is the fact that I had people around me who never gave up on me. Either it was my family, my friends, my school, or the health system. Because mental health conditions such as depression and anxiety could happen to anybody at any time during the life course, it is therefore essential that each and every one of us try to be more empathic, inclusive, and engage in a more open dialogue on the topic. Mental health problems in all its form is painful, and it really is a battle like no other. But I do sincerely believe that if each and every one of us works for a more inclusive, kinder, and more open society, as well as working towards strengthening the healthcare systems, psychosis like mine and other mental health problems in general will still tear you in half, but it will not be the end of the world, and it will not break you. Thank you so much.
Thank you so much, Kristen, for such a compelling and candid presentation. One thing which was very powerful, which you mentioned, that there were individuals who were too perfect to have mental health conditions. And when you realized that, you were shocked. And that's one of the crucial issues to accentuate or highlight, that mental health conditions are invisible. It could happen to anybody, anywhere across the globe. And in that case, we have to be, as you mentioned in the end, more inclusive, more empathic, and first accept the fact that mental health conditions are more universal and it will not break you. Now, we found out that Shrutilata is back. There was a power outage. Shrutilata, you want to continue and conclude your presentation before we have a quick round of Q&A and discussion and conclude the session? Can you hear us?
Sorry, we had short power cutting order. And so I don't have too much to say, but I will conclude it by saying that we do, now that we are all starting to talk about mental health for people with disability, we should always also focus how much accessible mental health treatment will be for people with benchmark disability, like people with deaf blindness. We have communication issues that we face with family and friends. And imagine what they will do if they have to go for counseling. Even at Sans India, we are having a project for mental health, and that is also challenging as we need to train psychiatrists and get assessment and data. So we are hoping that some results will be there in future. So wishing everyone all the best. That's all from my end. Thank you very much once again.
Thank you so much, Shrutilata, and thanks for mentioning the intersections between mental health conditions and other disabilities. And we have to look at this issue in a much more holistic way. Now, before I open it for Q&A, a quick question to the panelists, and perhaps either you, Derek, or Bhargavi, or anyone, Kristen, one of you could just jump in and talk a little bit about how could we move from the treatment fixing understanding to a much more human rights and inclusion understanding. Bhargavi, you mentioned about this in your presentation. I would want to understand from Derek if he has some insight on that.
Thank you very much, Gagan. I think there is a lot of resistance from people who treat, the people who determine the meals, and it's quite hard, because I can tell you, we have been back here home. Many people do not think about mental health beyond medicine, so they think everything will have to be fixed by medicine, and but that's the perception even in the minds of people who hold power. So it's not just about the general public, but even people who hold power. When I was listening to Christine, I kept on imagining, how do you measure progress in terms of awareness raising? Because it's usually what people do not know about mental health or disability and rights that causes serious problems. Some people probably could change when you talk to them, and then they know, okay, like what I talked about, social contact. There needs to be that dialogue where people with a lived experience have to sit down. When we used it here in Kampala 2 years ago, many people in the process actually disclosed that they have people in their homes with mental health problems. Something that they could not have done, because then they tend to identify with you, and you could see that it's just the bit of stigma. For me, I have always thought that Bhargavi talks about the paradigm shift, which is very, 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 very important, and the UNCRPD has given us that bit of platform. I have always argued here that community mental health service, because it's a cocktail, it brings in play the family, the role of the family in treatment, but also getting information. It addresses problems that now we are treating in hospital, like alcoholism and drug abuse. So people end up in hospital, and yet largely it's a social problem. So it's something that needs a lot of awareness raising, because you need to invest a lot in the preventive, more in the prevention and promotion. But I think it's kind of a general problem. The people with power, government, seem to be stuck. Even the partners that come to work with us in the South, think some of them tend to think that, no, I think the problem should have been medicine. You should be talking about absence of medicine. But there are many people on medication and they never get well. Actually, there are people who get worse after admission, surprisingly. So the hospital can be kind of what we would perceive as safe haven could be hell here on earth. So for me, I think it's going to take a lot of effort. The UNCRPD gives us a lot of courage, especially around Article 19, the one on independent living, making choices, the issues around legal capacity, personal decisions. There are many people, including people who treat, that when you have a conversation with a doctor, someone will never accept that what you are saying is credible, because there is that perception that, no, the problem, you have a mental health problem. So there is no, they seem to think that it's kind of a permanent condition, and you are always in crisis all the time, especially if you want to take them on in any form of argument or whatever. So I think it's going to take a bit of time, but like Bagavi said, it will require a lot of innovation, a lot of invention to see that we change these perceptions.
Thank you so much, Derek. Absolutely, it requires a lot of innovation and a lot of investment. And Bhargavi, perhaps you could say a word or two about moving away from the individual treatment-oriented model to a much more holistic understanding of inclusion, which promotes autonomy. Thank you.
Yeah, thanks a lot, Gagan. As Derek was speaking, and as Shruti, Christine, from different cultural contexts were speaking, one of the thoughts that struck me is what has helped us is the sense of community. Very often we do not think that being in a community can actually be supportive, and it can help us sail through periods of emotional crisis. Shruti talked about it in one way and Christine in another way. We work in the communities of Pune, as I mentioned, and it's I'm sure it's very similar to what Derek is saying in his community, or what Shruti is saying in her communities. This, in my view, is a strength insofar as we have well-designed community awareness programs, which is exhaustive. In medical treatment, you have just one strategy: identify the person with a mental illness and treat them with medicines. But actually, when you talk about inclusion, it needs to be population-based. It needs to address families and communities. And for us in the global South, reclaiming our communities and giving them lots of information, not about mental illness, but about the disability experience and about the possibility that people with disabilities are live contributors to their communities and society, that they can be very useful and productive if given opportunity. If the CRPD message can be brought live to families and communities, then communities can be the strength for persons with disabilities, and it's not just about psychosocial or mental disabilities, it's about all persons with disabilities. So we really count on our being able to reclaim communities and engage them in dialogue about the responsibility and mutuality of inclusion. And so we have to also package. Very often psychoeducation is like, this is the list of mental disorders, you identify and you send to the expert so that's not going to work. So sooner than later, we end up in the hospitals. And as Derek said rightly, for a lot of people, mental health care treatment itself is stigmatizing. It brings us out as more disabled. If you've stayed in that hospital for, like, we work on a deinstitutionalization project, many people said that, we are quite disabled by the drugs that we have been given over the years. And we are not in any position to, live an uninterrupted life in the community. So there is really no choice for us except to stay back in this institution. So there is that. Yeah, thanks a lot for this opportunity, Gagan.
Thank you so much. And you're spot on that we have to ensure that these institutions don't promote mistreatment or inhuman or degrading treatment of individuals, and treat them as individuals per se, and remove the stigma associated with this, and have much more inclusive communities wherein individuals with all ability status could thrive and flourish. Any questions from the audience? So while we are thinking, a quick question to Christine and Shrutilata. They talked about fitting in, the problem of fitting in, and the problem which also Bhargavi mentioned about what I have written as well, the tyranny of normalcy, that this is a normal student, this is a normal child, this is a normal employee, this is a normal life. How do we ensure that we free ourselves from this tyranny of normalcy. Any reflections, Kristen, you would want to add? And then I'll go to Shrutilata.
I think that the most important thing there is to break free from the idea, and that we try everyone to read more and be more inclusive and talk more openly about different topics like mental health. And if everyone talks more about it and we are living in a more open world, then I think also we can understand that there's no such thing as normal. I had a psychologist one time who said that it's more normal to be not normal than it is to be normal. And that really was an eye-opener, because I have this idea that everyone else is doing a lot better than me, and they're so much more normal and living so much not easier lives, but they're fitting in a way that I don't feel like I do. But when people open up to me, I understand that they all struggle with the same things. So I think that the more we open up, the more we also can see that there is no such thing as normal.
Absolutely, yeah. And this aspect of looking at other people's lives and thinking that how amazing or glorious or positive or empowering those lives are is exacerbated by social media, which has a very perverse effect on mental health conditions. Absolutely. Shrutilata, do you have any input on that? Like, how do we ensure that we can break ourselves from this tyranny of normalcy?
Well, in my view, everyone has having some kind of mental health issue. So, from disabled perspective, only we can understand. If we want the community to understand, then there is a lot to be done. I mean, we have to sensitize them and create more awareness. But they have to make different approaches. Like, we cannot make them understand how blind feels just by doing blindfold and making them walk. It may be having negative effect on them. But if we want them to understand, then it is better that we have to make sure that people with disability are mixed up with those without disability, so that slowly they can understand. From my own experience, I can say that earlier, when I was not able to share how I feel with others during school time, then I was my feelings was exploited. I mean, they did abuse and neglected me. But now, when I make friends, I just am frank about sharing how I feel and what I need. So they are able to understand and support. They cannot do 100% as per what we want to, but at least they try. So
I think we lost Shrutilata, but her important message of making others, people understand by raising voice and advocating for rights is something which is quite crucial. This is the same message which we heard from Kristen, quote unquote.
I should be sharing about it instead of hiding it.
Thank you, Shrutilata, for that point. A quick point from Fikate. Fikate, do you have any input with regards to what has been a successful strategy in the TOFI consortium with regards to promoting or ensuring the rights of children with psychosocial disabilities in Ethiopia?
What we do is we try to educate the community in different sectors, and also the school community in particular in different areas, like not only psychosocial disability, but all the disabilities are possibility for everyone. So we try to educate that those individuals with special needs are not unique individuals. Anyone can have that kind of experience at any time, at any point. So we try to educate the community through different kind of things. Through leaflet, we prepare leaflets on this issue and we distribute in the community to create awareness, as well as we do a kind of campaign in the school, like in different days like Autism Day, so that the school community can learn what kind of kids looks like autistic and how can they can be inculcated or included in the school system. And also we try to do the advocacy with the government to include these kids in different areas. Like there's inclusion in Ethiopia, but it's not inclusion, it's not pure inclusion, because there's only the name inclusion, but systematically they don't include the kids because they assess in the same kind of areas, and also they provide in the education system is the same for everybody. But some kids with special needs, especially like ADHD, autism, they need a special kind of education systems. So we try to provide information for the school systems as well as the government in education, in Ministry of Education, to do this kind of things, to look at the kids in a different way. They are the same, but they need a different kind of approach to be productive. So with psychosocial disability, we did the same. We teach the school systems, the students, to include the kids and to see that they are normal, but they explain themselves in a very different way. So they can include them without any neglecting their needs as an individual. So at the hospital also, we are fighting that the hospitals should see this kind of issues in a different manner, because they need a different attention, but they are not different, but they need a different attention. They need a different approach, like any one of us. Every one of us has a very different, unique character. So this kind of people with special psychosocial disability needs a different approach. There's no different interests, but we can, as a community, what we're trying to do is like, we try to teach the school community as well as the community in different areas. So by doing that, we can, I think, change like from treatment to inclusion, because if we work at early age, most of the things can be lessened. The effect would be less. But we try to psycho-educate the kids how to do like relaxation techniques, how to do stress management by themselves, so that whenever they feel like intense anxiety, whenever they feel anxious in the tests, we taught them that the techniques to lessen their emotions, so that their effort would be fruitful. So
thank you so much, Vigate, for that intervention. I'm sorry, I'm cutting you off because we have a question, and I don't. It's a very important question. Has the education within the community helped individuals with psychosocial conditions? That'll require a long answer, perhaps another session, but we don't have time for that. But I would like to briefly mention a couple of things. That, of course, isolation, alienation, and separation in the recent times, especially after the COVID pandemic, has led to the pandemic of mental health conditions. It has skyrocketed across the whole globe. We have heard from the fantastic, phenomenal panelists that it's a much more universal problem. There's a problem to fit in. There's a problem with regards to tyranny of normalcy. There are issues with regards to how individuals with psychosocial disabilities are seen through the lens of fear and danger and through the lens of superstition. But there is a way out, and one of the ways out is to first acknowledge that mental health matters. Mental health conditions could happen to anybody across the globe at any given point in time, and it's the community solutions which are so crucial. We have to go beyond the paradigm of fixing individual, treating the individual, but rather creating communities, structures, support systems which are inclusive and which nurture individuals to flourish on an equal basis. That's what we have to do. So thank you to all the panelists, Derek, Fikerte, Bhargavi, Kristen, Shutilata. Thank you to all the participants. Thanks for your question as well. I'm sorry we could not address that because of the shortage of time. And thanks to all the sign language interpreters, live captioners. Thank you to my colleague Johanna Rai, who is helping with the technical facilitation. And until next time, goodbye from now. Stay safe, stay happy. Bye-bye.